ADHD. Before we begin today, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself on the Central Coast, that is Darkinjin land, and I'd also like to pay respect to elders past, present, and emerging. Now, my name is Sydney Cruikshank, and I'm from the PHN education team. I'm joined today by Dr. Jyothi. Jyothi is a psychiatrist on both the Central Coast and the Northern Beaches Hospital. Now, a few things to let you know about the session. It will be recorded and available for you to view in our education library in a few days' time. As attendees, your camera and microphone, you have full control over it, but we'd prefer if you can just keep yourself muted throughout the presentation. And then besides that, we have an evaluation that will come to at the end of the session. We'll take you through that Slido located in the top of the control panel in Teams. Now, we also have some additional questions from Dr. Jyothi, so we would really appreciate any of your feedback from that. And then we have Dr. Rubin was our winner from our Lucky Door prize for last week, so he will receive a $50 Prezi voucher, and then we will be selecting another one today. So any contribution or participation would be greatly appreciated. Now I'll hand it over to Dr. Jyothi, and I'll also say hello to our GP facilitator, Georgia Page, who's here.
Good morning, everyone.
All right, take it away, Jyothi.
Thank you, Georgia and Sydney. Thanks for having me here. And it's nice to see some names from the attendees list who have never met before. And thank you for your support and sort of looking after some of the patients in a shared care model. Now, today's topics, adult ADHD. Georgia wanted me to talk on this topic, and so as we all know, it's been quite topical for a few years. And to be honest, when we trained in psychiatry, doing training in the public sector, you hardly get any exposure for assessment or treatment of adult ADHD at all. And then I think it's really kind of pick things up as you become a fellow and start to work in a private practice. So I've learned about ADHD over the last sort of 10 to 15 years, largely through attending courses and gaining clinical experience, based on the knowledge you gain from the courses. So I'm no expert, but I certainly see a fair number of patients with adult ADHD. So I'll share with you what I feel might be relevant for the GP world. So we're talking largely about ADHD in adulthood and the diagnostic criteria, use of rating scales briefly in terms of what might be relevant for your practice, the general principles around assessment management. And I will present a case vignette. It's a sort of a rather simple, straightforward case, but sort of the type of patient that would be mostly seen in a sort of shared care model, I suspect, which is where we might be heading to in the future with the sort of the work, the resource issues and psychiatry in general. So what is adult ADHD? It is a neurodevelopmental disorder that starts early on in childhood. And the evidence for this disorder can be tracked back to sort of early childhood, and if the adequate history is available, and it persists in adulthood in majority of patients, and a lot of them have subsyndromal features, and they occasionally limit. And the condition is largely characterized, as the name says, by the symptoms and features of inattention, hyperactivity, and impulsivity. There are high rates of psychiatric comorbidity, which can make the diagnosis and the treatment complicated in some individuals. This is a male preponderant condition with a ratio of 4:1, and this sort of ratio kind of becomes less in adulthood, probably due to better identification in females as they grow up. So why is it important to identify? ADHD is a disorder that causes a whole range of problems in health problems, psychiatric comorbidities, the present psychological dysfunction, occupational and academic failure, and social disability and engagement in risky behaviors, which have their own consequences. So it is a disorder that sort of spans across a person's life, or can span across a person's life. And early on in childhood, and it can manifest or co-occur with learning disabilities, executive dysfunction, disrupted behavior, mood, anxiety problems, developmental issues, impaired social development, and emotional dysregulation, underachievement in school, in a tendency to be prone to accidents and injuries. And through to adolescence, they can have sort of psychological consequences due to sort of impaired sort of social relationships, low self-esteem, and unplanned early sort of pregnancies that can have their own sort of consequences. And moving into the adulthood, one can expect to have difficulties at occupational performance, unemployment, underemployment, suicidal behavior, relationship difficulties, criminality, obesity, and so on. So it can have a quite a range of consequences. So hence it's important to identify wherever possible and treat it to the best of our abilities. And premature mortality is a big concern, and people with ADHD. They have a twofold increase in mortality in less than 60-year-olds, 6 to 17-year-olds, looking at 1.5 times more mortality, and 18-year-olds and above, you've got fourfold increase in mortality. So just briefly on epidemiology of this condition, children and adolescents have 6 to 8% as a prevalence. In adults, it's somewhere between 2 to 6%. There's a massive social and economic cost, approximately $25,000 per person with ADHD per annum. And majority of the children with ADHD, while they might not fulfill criteria as an adult, they might still have functional impairment or subthreshold sort of impairing symptoms. And that can occur in 2/3 of youth who could get into adulthood, and it can manifest impairing symptoms. And the reality is that even in adults, only about 20% of the patients with people with ADHD are actually diagnosed and treated. So there is a sort of an increased unmet sort of need there, and which is what we're all sort of struggling to cope with. So when would one have to think about ADHD? These are some of the sort of red flags. Patients may or may not present with these concerns themselves. They might this might be something that you pick up during your sort of interaction with the patient. So the typical difficulties an adult would be around organizational problems, erratic work or academic performance, anger management issues, marital difficulties, or difficult interpersonal issues, difficulty organizing their household routines or self-regulating behaviors, managing finances, various types of addictions, accidents and driving issues. And having a direct relative with ADHD also increases their risk of having ADHD if they're presenting with other concerns that might suggest ADHD. And often in the sort of university going students or and sort of adults who are pursuing other sort of academic pursuits, they might have difficulties in completing their assignments or in having to reduce their workload, the course load, and so on. And all of this can lead to sort of a chronic sort of sense of underachievement in their lives. So this is just a DSM criteria for ADHD. Obviously, there are two clusters of symptoms: inattention and hyperactivity and impulsivity symptoms. There are about 9 symptoms in each of those in a cluster. And for an adult to be diagnosed with ADHD, they have to have 5 symptoms in either of these clusters, or 5 in each, which would make it a combined type of ADHD. might not go through the entire criteria, but it really talks about sort of inattentive issues, how it can manifest differently in giving close attention to detail, making careless mistakes, difficulty sustaining attention and task, not being able to listen when spoken to directly, and not following through on instructions and failing to finish work, organizational difficulties, difficulty engaging in tasks that require any sustained mental effort, losing things behind or leaving things behind and not remembering where they've left, easily distracted by any extraneous stimuli. And then this can be just one's own thoughts, for adults, and generally being forgetful with their sort of daily activities. So hyperactivity, impulsivity symptoms, being fidgety, leaving their seats when they're expected to sit, particularly in meetings or in other sort of workplace situations, feeling restless, being on the go, and difficulty engaging in any activities quietly, and the tendency to talk excessively, blurting out answers, interrupting or intruding others, and having difficulty waiting for their turn. So as I said, at least five of each of these, or either of these, symptom categories should be present, and there should be several symptoms present before the age of 12 years, which is what is often very difficult to establish, when you've got an adult in the Middle Ages sitting in front of you. And the memory is often also sort of impaired for those years because of the time that elapsed between, but also generally, people with ADHD also don't recall, information from the distant past all that well. And several symptoms have to be present in two or more settings. And impairment is a big one, that there's a clear evidence of impairment in terms of how they're able to engage socially or with schoolwork or work itself. So, and the other sort of big one is that the symptoms are not better explained by any other mental health condition, and they make a specific mention about schizophrenia because a variety of psychiatric conditions do have symptoms that overlap with ADHD. So one has to be careful in making a diagnosis when there are comorbid conditions. So the subtypes are inattentive type when they just have inattentive symptoms, or hyperactive and impulsive type, when they just have those symptoms, and combined type is where patients have adequate number of symptoms in both categories. In adults generally, you would be finding less and less hyperactive and impulsive symptoms, and it'll more look like inner restlessness, feeling like they have to move a lot, or just sort of aimless pacing or wandering, and having to take frequent breaks, or and so on and so forth. So the general principles in terms of assessing someone with ADHD is that a diagnosis should not be based solely on any rating scales, because that can a positive rating scale means that they have certain difficult symptoms, but doesn't necessarily amount to an ADHD diagnosis. And that should be really further established by observations or report from more than one setting, confirming the symptoms and the functional difficulties in those settings. And inattentive symptoms can be hard to identify up until like secondary school age, particularly kids who are reasonably bright. They might be able to function well in a primary school environment, but as they get to sort of a high school, where there's a lot more expectation for them to be independent, then symptoms can manifest because of their inability to organize and to show self-initiative. And so the individuals can also compensate for strategies and mask their symptoms. So that can be hard to sort of that might look like they didn't have any symptoms at all, up until the recent years and so on. So it's always sort of good to explore if there was a period of good functioning, how they functioned, and what made them actually do better in that period of their lives. And neuropsychological testing is not necessary for diagnosis. It's largely a clinical diagnosis. So just briefly on rating scales, this is the ADHD, adult ADHD self-report scale symptom checklist was developed by WHO. There's a part A and a part B. Part A is it can be just used alone by itself. Both of them, when you download it, it actually is on a single page of paper. It's available for free online. So part A, is can be alone used as a screener. So when you look at these, there's a combination of some, inattentive symptoms and some hyperactive symptoms here. And if patients are sort of, ticking one of these sort of shaded boxes or a lot of these shaded boxes, then, your index of suspicion for ADHD, it can be higher. And then you might, even want to do the part B, which is just in the bottom half of the same paper, which is really just focuses on even more questions, eliciting other symptoms in different situations. So, if you're having a lot of these sort of positive responses in these shaded boxes, then you might then consider a further assessment and a referral. And the other questionnaire that might be of use is when the UTA rating scale, with just 25 questions. It's available online. It is a self-report questionnaire focusing largely on childhood symptoms of ADHD. And so this is just a historical sort of symptom evaluation, and the cutoff of 36, on that scale, has a 96% sensitivity and specificity for the diagnosis. So this could be also used to supplement your adult ADHD self-report symptom checklist. Now, obviously, we want to rule out organic causes, when one's presenting with cognitive difficulties largely, and the key ones to rule out would be thyroid impairment, hypoglycemia, severe anemia. Lead poisoning is a concern, probably in children in the developing countries, and sleep disorders can look like ADHD in some, and so that would be important to rule out, at least by taking a history. And fetal alcohol syndrome and other medications can also have cognitive effects which can look like ADHD, like other psychiatric medications, or even a medication that can have an activating effect, like beta agonists and deconditions, which can also make one look like they have ADHD symptoms. So once the screening's done and the medical workup's done, and this is what I kind of tend to do. This is where the psychiatrist comes into the equation, and I'll just briefly take you through how we go about the assessment. So it might be helpful to share with patients what to expect. So really confirming the presence of impairing ADHD symptoms that you would have already sort of elicited in your screening questionnaires, and this along with impairment of impairment caused by these symptoms across various aspects of their lives and across the lifespan. So we would go through accounts of childhood, early childhood, primary school years, high school years, and if they had any further education in those periods, and employment, in a variety of employment, and what types of jobs that they did well at, and what types of job they struggled with, where there's certain aspects of their job that they're generally good at, and some aspects that they're struggling at. So that all those things will help identify the symptoms and the impairment and their own sort of compensatory and coping strategies. Of course, family psychiatric history is important, not only for the presence of ADHD, but also for other disorders. And a bipolar disorder can be, highly prevalent in people with ADHD and in families of people with ADHD as well. So that can be something to, important to establish. And we also look at psychiatric comorbidity, um, and not only in terms of trying to understand whether there is another explanation for the ADHD-like symptoms, but also to look at treating other comorbidities, so you get the best outcome for the patient, because other comorbidities can also be contributing to impairment, and treating ADHD alone might not be sufficient. Rating scales, I might just add another rating scale or two if I feel necessary. But once these basic rating scales are done, I don't really see a need to do much. And other perinatal exposure, developmental milestones, I've already talked about some of these things. And occasionally, when it's difficult, I might, if it's a complicated sort of situation, I might do an ADHD specific diagnostic interview, which is really a structured interview, looking at various symptoms, each symptom, and examples of the presence of those symptoms in different areas of their lives. This is the questionnaire I tend to use is one called DIVA 5, which is validated, and it's available for a small cost online. So once an assessment's done, a diagnosis is established, the goals of treatment are really to reduce symptoms, improve functioning. The obvious ones really removing barriers that will keep the person impaired, and addressing any comorbidities. I might just move to a case vignette and see how we go for time, and if we're pushed for time, I might just stop at the end of the case vignette. So it's just a 27-year-old man. Sorry, there's that typo. De facto relationship, has two children, preschoolers, and the referral came from the GP. Obviously, I think he went in to see the GP, asking for a referral for an assessment for ADHD, and he was employed as a software developer. So he said that he was basically Googling his concerns, and ADHD came up as a possibility, and so this is not kind of uncommon. So he said that he really struggled to articulate his concerns, and it took me a while to actually elicit from him that he came in for two reasons. One was, he was retrenched from his previous job, and he had just gone into a new role, and wanted to do better in this new role. And there was poor performance, or feedback from about his poor performance at the time of him being retrenched, and which he kind of surprised him in some ways. And similarly, his partner also had given him similar feedback about him not listening well, not taking in information, and so on. So I think the feedback from the previous employment was also similar, that he was missing details of information from meetings, and so his work was not up to expected levels. And it was very difficult to get any other concerns, and he was just going all over the place. It was the interview after about 20-30 minutes, I felt like it was going nowhere. But that can be a very common presentation in someone with ADHD, that they really are struggling to organize their thoughts and share their concerns in a coherent manner. So I jumped straight into doing the ASRS, to see what the areas of difficulties were, and then it was obvious that he was scoring highly on the ASRS, which I just showed earlier, and it transpired that he had difficulty completing his work projects once the challenging aspects were done. He said that he would work in 6-week cycles of completing a project. He'll start with a high level of interest in a week 1, week 2, like really switched on doing things. But as he did all the sort of interesting bits, he will become less and less interested, less productive, and leave it to the 6th week and just rush it up, and then there'll be sort of mistakes in his work and so on. And he said that he would have difficulty remembering to attend meetings, and set reminders, and ignore them or not pay attention to them. And starting any sort of complex tasks was difficult unless he was absolutely interested in it. And also having great difficulty, being focused in meetings and taking information in. And individual conversations was also difficult. He said that he'll often check with the person that he would talk to whether he's understood it correctly or not, but then realize that he has only got part of the information in. And he also, endorsed certain hyperactivity sort of symptoms. So we're looking for comorbidities. There was none, except for maybe poor sleep quality and having a poor sleep hygiene. And there was a maternal uncle and a cousin who had substance misuse problems. The substance misuse also occurs in highly comorbid in people with ADHD, although they didn't have any ADHD diagnosis. And in his schooling, in the history, establishing his childhood symptoms was very, very difficult. He said that he was told in kindergarten that he had to repeat, but his parents don't, believe what the teacher said. The teacher's feedback was he wasn't paying attention. He was not taking instructions. He was doing his own thing in class, and they didn't believe it, and they just simply asked the teacher to move on. And he did all right, an average student, and in primary school and high school. He did exceptionally well in software and IT, and he pursued a bachelor's in IT. And there was a discrepancy in his sort of performance in his university as well. Like he did well in his sort of practical assignments, whereas any sort of formal tests or exams he didn't do as well. He still got some D's and with some credits. So really, based on the information I had, he was reluctant to, get his parents or anyone in for an interview because, he didn't think that they'll be helpful in helping with the diagnostic evaluation. So given the level of impairment, he had, and, he was starting a new job, he was really keen not to mess that up. And so we started him on a trial of, medications after, looking at his ECG and all that being fine. And he initially had a good response, and he was feeling positive about his, performance at work. But there was the problems with wear-off effects and in between doses, and also in the evening. So we tried him on a long-acting Concerta, and that wasn't all that effective. And so while we were doing this, we also noticed that his blood pressure was, going up. So this was managed by the GP and brought it under control. Then we moved to a different long-acting medication, lisdexamfetamine, and which was quite effective. And as symptoms overall improved, and he was quite satisfied with how things were, except he had wearing off of the effects of Vyvanse by about 4 or 5 p.m. So in the evenings, to manage his sort of domestic responsibilities, he was struggling. So we simply added a small dose of dexamfetamine at that time, which sort of gave him good coverage for the whole day, really. And he was stable for many months. And he then brought his mother in, mainly because he wanted a PBS subsidized script, which is a requirement. It's a requirement to confirm retrospectively at least the presence of childhood symptoms. And so she was able to report some some symptoms, but it was it wasn't, she didn't have a great memory of his childhood sort of presentation either. So given the response, we simply continued him on the regime. and he maintained a good lifestyle. He maintained his employment, and sadly his relationship broke down. But he said that wasn't because of his condition. They just kind of grew apart, and he wanted to simply be followed up by the GP, and I organized that with the GP, who was able to then pick up the prescribing, using the authority, an individual authority application, and he only now needs two yearly kind of follow-ups, with me, and that's just to really check in to see how things are going, and not much, has changed. He remains quite stable. I am aware, sort of half an hour into it. I've got a bit more on sort of pharmacological, sort of general aspects of management. Should we, Georgie, what do you think? Should we stop there and take some questions?
A few questions. Do you want to go through a few questions first, and then we can continue? So, this is a question about the ASRS. Is it a good screener for ADHD? So, from and sensitivity, specificity point of view.
Yeah, look, it's a validated, sort of screener, really. I think the screening, these screening questionnaires are recommended by the Australian ADHD guidelines, which was published this last year, for the first time ever. So, and also the Canadian guidelines, which has been there for a few years. So I'm not exactly sure about the specificity and sensitivity, but those numbers, but sort of fairly recognized by both the guidelines.
Sorry, just to follow up on a question there. I think, sorry, I was going to ask a question. My biggest concern with the ASRS is that because they have 5 columns there and self-scored as well too, it's very easy for the person to actually put themselves on the highest column for everything, but it may not genuinely be that way. But also, so too, because the boxes themselves are color-coded as to which ones are actually weighted heavier, it also actually has another level of danger involved in that process.
Yeah, no, look, I fully agree, and I think that's the problem with all self-reports, and most of the questionnaires are really self-reports, ADHD questionnaires, and except for in the corners, in a parent and teachers rating scale, and children, where you're able to gather information from other sources. But even these questionnaires, I would sometimes ask the family to do it. I mean, it's not that even though it's a self-report, they can sort of make a report based on their observed experience. Although some of the subjective, sort of symptoms, they won't be able to comment on, but other questions might still be relevant. Other, if our family or other, relatives and friends can do that. And look, I mean, this is the inherent problem with, I feel with, ADHD sort of, diagnosis, that there is a lot of thinking, discussing, doing questionnaires online, and sometimes if they've also seen a psychologist, doing questionnaires with them, and all of this sort of, really, starts to shape one's, understand one's, sort of illness model or an explanatory model, in a way that, they then think to almost believe that, they definitely have ADHD, and that's the reason why, or why they're having difficulties. And it always sort of, my heart sinks, when a patient walks into my rooms and says, I know I have ADHD, I just need it to be confirmed, then, that really, sets up the tone for the rest of the assessment, that, that you don't really have any room to assess, and have an open dialogue. And it's but interestingly enough, it's those types of patients where I have also found other concerns, that might, explain, their, impairment and, symptoms, and then that discussion becomes very difficult, and quite often those patients, don't return, they're probably seeing someone else who will confirm the diagnosis, I suppose. Yeah.
I suppose that goes with Ian's question, which was, the patient that Googles it, they put themselves in that diagnosis. Is a trial of therapy the only way to work out, I suppose, if it truly is ADHD or?
Sorry, I missed the second part. I'm
sorry,
I'm just looking.
So with the patients that self-diagnose and they come in, and it's hard to differentiate between those that have really got it or not. Is it a matter of, if they respond to medication, and yes, that may confirm the diagnosis, like a trial of therapy?
Look, the response to medication doesn't necessarily is not diagnostic, really. I mean, all of us could take a bit of Ritalin or dexamethasone and feel a bit better, I suppose. And I think like I suppose caffeine does. I mean, caffeine and caffeine's cognitive enhancing properties, and most of us are sort of familiar with, really. So so I suppose in a small dose, it might not necessarily be diagnostic as such. It might just make you, because of that sort of the dopaminergic sort of that basic sort of change you get in the dopamine. It'll have some feelings of well-being, cognitive alertness, and so on. So not necessarily helpful. I think that's why what's important is to try and use other sources of information, family members, partners, parents wherever possible, looking at sort of school reports, to see whether there has been a persistence of difficulties, but with the caveat that some adult patients might not have had teachers might not have seen problems in the same with the same lens as the teachers these days would have, and so the reporting might not be that accurate about their difficulties or impairment in school, and also higher functioning patients might not have difficulties even up until like they hit university even, and I think that's where the exploration of compensatory sort of features, if there is apparent absence of symptoms, is sort of relevant.
Yeah, and Kelly's certainly commenting on that. There's a lot of adults who have self-diagnosed ADHD who have 1 or 2 degrees and a few jobs and married with kids, and they've obviously compensated all this time. So but then it's just sort of coming to light now because obviously they've got all these competing factors in their lives. Is that sort of a common scenario you're seeing as well? I know we do, but
yeah. Look, I mean, that's a difficult one. I think it's it's not uncommon for really high functioning individuals in a tertiary qualifications, having a family. But I think those sorts of the one way to understand one way that I think about that is that they in the history, what I try to establish is that have they always been working hard, like even in university, where they putting in 10 hours of study, as opposed to 5 hours of study, that their peers would do, is that how they've been compensating, and working long hours, staying back, and where the colleagues sort of doing a similar amount of work might not spend so much time. So all those things, right? And so it adds up, right? In a university, then you have a job, maybe studying part-time or doing your own sort of professional development, and then family, kids come along. Kids might also have some sort of difficult issues around sort of their own organizational issues and whatnot, if they've got the same genes, and so things start to add up, and you sort of hit a threshold point where you are so aroused every day, you're not sleeping well because there's always sort of this sort of chasing the tail, so to speak, and so if it's that sort of picture, then I'm quite comfortable to make a diagnosis of ADHD and give a medication trial, and practically, if that helps, if they're then able to sleep better, if then they're able to, feel calmer going about their day, not waking up and dreading the day, and so on. So then that's sort of confirmatory enough for me. Whereas if you're not able to establish these things, then is this someone who really has higher aspirations than they can reasonably achieve?
And anyone else that got any questions, put your hand up, or we can chat in the chat box. One other question I have is, how do you determine which medication to start someone on? Like, is it a different approach to in ADHD in children? So what's your formula?
Look, I tend to start most patients on really Ritalin, because I think it's a bit better tolerated, and also if there is comorbid issues around anxiety or even a mood disorder like bipolar disorder, there's less risk of sort of complications with Ritalin, whereas dexamphetamine it's a bit more potent sort of dopaminergic kind of drug. So patients can, particularly women, can also be sometimes more susceptible to side effects from that medication. So I'll start with really Ritalin, short acting, and with the need to sort of switching to sort of a long-acting medication, for ease of use. People might find it awkward to sort of take a dose middle of the day at work or in university. So, and also the pharmacokinetic profiles are kind of quite nice with the long-acting medication. You get a sort of a steady sort of steady build up of the level of the first 1 hour to 90 minutes, and then it stays at that level for however long, 8 to 10 hours, and then wear off in the evening. Now, so there is that. So that you don't get those sorts of wear off effects in between, or drop in kind of levels in between, which can be problematic for some individuals, like for this patient I just presented. So I think ideally, moving to long acting wherever possible, but some patients have such differential responses. They'll respond so well to short acting or vice versa, and then you just stick to what works best for them. I mean, lisdexamfetamine is quite commonly used, the long acting, because if it's a sort of really long duration of action, and when patients don't respond all that well to Ritalin, I'll go on to the dexamfetamine or lisdexamfetamine options.
And Dimity is sort of highlighting, I suppose, here the importance of sort of the psychological strategies. So her granddaughter was diagnosed with ADHD, and the psychologist recommended organising the house in a way so she can get all her tasks done. So I don't know if Dimity, do you want to elaborate on that question a little bit more? Oh, you need to.
Yeah, look, yeah, definitely. I'll just the non-pharmacological sort of aspect of management. That's really the a big issue, and I think as we could do a lot to sort of promote that, because quite often patients come with the expectation that they'll walk away with the script and that's going to change their lives, and I often really say that the medication really will just allow your brain functioning to be at an optimal level where your environment and everything else is adjusted accordingly. Then you as a being can sort of function to your best in that sort of environment. So I think that's really very important. So the ADHD brain is a sort of a almost like a reward-seeking brain, right? And so anything that gives sort of an immediate sort of gratification or an immediate result is what it'll tend to drift towards. So I think depending on what the person's age is, what their roles and responsibilities are, one has to really optimize the environment. If it is a work desk, what's got to be in their work desk? Should their phone be there? What are they? How are they going to use email systems effectively, or are they going to be responding to emails all the time and not to get the work done? So really, those sorts of strategies around how to limit those barriers, that it's going to continue to impair them, is going to be very important to address. And also, sometimes patients are entitled, right? And it's often the partners and in a family, bring this. So there can be sort of some work done in those sorts of patients in addressing their awareness and understanding. And because this is when we see in adults, this is something that they've sort of lived with for a long time, and they've developed patterns of avoiding things, or doing things a certain way and thinking about things a certain way. The moment they get an assignment that they have to do, they might go, oh, this is just too hard, or this is just going to be boring, or and then I'll come back to it after after I've played after I've been on a run, or whatever it might be, right? So I think really those sorts of cognitive sort of processes that become sort of second nature and almost automatic, because of years of living with this. So those needs to be, those sorts of processes need to be managed and addressed, and really looking at the compensatory mechanisms, what's helpful, bolstering them, what's not so helpful, and working out other strategies to manage that. And also really, all of this happens in the context of life, and so really helping the person manage other stressors and so on. So look, I think I can't emphasize enough that medication, when medications started, really having optimal input from a psychologist, and there are ADHD coaches, and their sort of level of skill and expertise is variable. So I think finding a good ADHD coach can also be helpful. Yeah.
And Ruben, you had a question. Oh, Ruben, you might need to unmute.
Oh, can you hear me now?
Yes.
Yeah. So, Jyoti, I had a quick question. I have a patient who is a builder, and he said to me, "Oh, I can do my all my work from 8 to 5, the building work, and then 5 o'clock I sit down to calculate the wages of my staff, and what I can finish in 15 minutes, I'm taking 1 hour, and I haven't still finished it." Anyway, I said to him, "All right, I'll send you to a specialist," and he got diagnosed with ADHD. And then he comes back 6 months later and says, "Oh, now I'm finishing the calculations only in 10 minutes, and I'm done and gone." And so my question was, does it mean if you're doing, he's like a builder, owner builder, so he's probably, I think, doing a lot of supervising rather than getting the hands on. But does it mean like building type of work, you don't really need, even if with ADHD you can manage, but something that needs higher level of functioning, is that the thing that is affected in ADHD, or is that the thing that is more affected? And so if you are doing some academic work or something, you could be hampered, but if you are doing a laboring type of job all your life, the ADHD really doesn't affect your life.
Yeah, look, I think it's possible. I mean, I think there is a sort of a natural kind of drift towards the types of jobs one might actually be comfortable with, and I think that does occur. A person who is hyperactive, highly energized, worked out during the sort of adolescence, that if they run for 2 hours a day, then they feel better and calmer and whatnot, and so then they'll sort of drift towards sort of physically demanding and challenging kind of roles. But of course, the ADHD in a pure sense is sort of when you look at sort of Russell Barkley, was one of the researchers in ADHD. He talks about it as an executive functional deficit, and so it's not only to do with attention and sort of organization of thought and learning and so on, but it also sort of influences in a mood regulation, in a behavioral regulation, and sort of a response inhibition, and so on and so forth. So, I think some patients might have a subset of symptoms that are problematic for them, whereas not the other sort of sets of symptoms that we would expect to see for this if you just build a patient of yours. So long as he's, if it's just that sort of aspect of him being able to sort of sit down and do his sort of paperwork is problematic, then one might even argue to even need to treat it, right? I mean, or does he just need one dose of medication? Whenever he's sitting down to do paperwork, that might be reasonable, or he might be able to delegate that to someone else too. Who knows? But if he's also sort of shouting at his workers and irrationally and not being able to maintain a good workforce and having a go at his children all the time, and having poor relationships and so on. So I think then it might be reasonable to sort of treat his sort of ADHD, not just with medication, of course, but with other approaches as well, as we previously discussed, in a bit more robustly.
Thanks.
Don't know if that answered your question. That was sort of long-winded. Sorry.
Yeah, mainly what I was thinking was, if he has ADHD, his whole day 8 to 5 work would be all disorganized, because he probably couldn't organize himself the whole day. So I was just questioning, how do you manage your 8 to 5 in a proper way, and then only the calculation part is a problem. So does he need to be sent for a maths class and not the ADHD medication?
No, look, that's a brilliant point. He might have a specific learning disorder, like dyscalculia, sort of a specific sort of mathematics sort of disorder. So I think when you see that sort of level of discrepancy, in sort of impairment in only certain aspects, he might actually benefit from a more thorough neuropsychological assessment, and that's that's important to sort of tease out whether it's just a manifestation of a learning disorder, really.
Thanks, Jyoti.
And Jyoti, there was a slide, I think, on the medications. There was a request to go through that slide. I don't know if it was before this slide.
Yeah, so these are the 3 slides on medication. First line options are, methylphenidate, dexamphetamine, lisdexamfetamine, stimulants generally, and the methylphenidate formulation is our Ritalin, which is a short-acting version. These are average sort of duration of action, 4 hours, 8 hours, 8 to 10 hours. But generally, Concerta doesn't actually last all that long. Maybe 8, close to 8. And as I said, long-acting preparations preferred for convenience, adherence, and storage and administration. Concerns around misuse is a big one. When you might want to use long-acting, less likely to be diverted. And the pharmacokinetic profile, because of the less wear-off effects through the day, and also less peak sort of related side effects as well. And we might have to combine long-acting and short-acting just to get the day covered for some individuals who need a full day sort of coverage. And non-stimulants, alpha-2 agonists are the sort of the next sort of next in line, clonidine and guanfacine. And clonidine tends to have a bit more side effects than guanfacine, mainly hypotension, bradycardia, and sedation can be helpful. Particularly clonidine, you'll see a lot of kids on with hyperactivity on clonidine, a small dose of clonidine at night. I tend to use it as well in adults too, to manage any hyperarousal at night that sort of impairs sort of sleep onset. And and the dosage range is 100 microgram to 400 microgram per day. Gonfacine is 1 to 4. And gonfacine is only TGA approved for children and adolescents, and clonidine's not approved for ADHD treatment in Australia. Sorry about the typo there. And really, other non-stimulants used, bupropion, which you might be familiar with. That's used in smoking cessation because of its dopaminergic reuptake inhibition. And I already talked about clonidine. Modafinil, hardly ever, and I don't have much clinical experience of using it. It's just so expensive to prescribe. But there's some very limited evidence there. And reboxetine and venlafaxine can also be used, and so can some of the tricyclic antidepressants, which I've not got here, largely because of their sort of monoamine reuptake inhibition, largely not adrenergic reuptake inhibition. Venlafaxine at higher doses also has a dopaminergic reuptake inhibition, so which can be helpful. Yeah.
And a question regarding, I suppose, share prescribing. As GPs, what should we be monitoring in our reviews? Like any specific symptoms we need to be looking out for, like obviously checking blood pressure, etc.
Mm-hmm. Yeah, look, I mean, I tend not to use rating scales after that sort of initial assessment and initial response. Really, I think it becomes a bit of a sort of a tick box exercise. I tend to sort of really talk to patients and try and get a sense of qualitatively how their functioning is. Looking at various aspects of their lives, and I'll sort of go through each domain really. To tell me, has your work situation changed? Are you still employed in the same role? How's your performance been? Has there been any difficulties? And try and get a sense of where that's at. And similarly, if they're in a relationship, family, I'll explore sort of their functioning around that. Responsibilities. It's just really going blow by blow. Okay, weekday functioning, weekend functioning, leisurely activity participation. What are they like? Have they had any other things that sort of sprung up, like if they had any legal issues, speeding fines, and so financial management. So just once you get to know the patient well, I suppose you'll be more targeted in what you would then want to ask. You might not want to explore everything all the time. We won't have time as well. So I think that's how I would sort of go about it. And generally, patients are good in terms of telling you whether the medication's going well or not. And if they're not, if it's not, then I sort of tend to understand why. And that might be because there's something else stressful that's happening. They're sort of they're even more stretched. They might need some sort of psychological sort of support, or they might be depressed. Who knows? Things can emerge. So sort of really exploring those things. And very early on, I suppose this is probably a relevant thing to mention. Patients will initially come back and say, "This is fantastic. I'm doing great, and I feel good." I mean, that's a point to note. The feeling good is really a sort of a dopaminergic kind of that sort of phasic change with dopamine that you get with a short-acting sort of dopaminergic drug. And so I will warn patients that look, you might not feel good in a few weeks' time, but it's not. This is not to really make you feel good. This is just to make you do well, make you function well, make you kick the goals that you want to kick. So that is the treatment aim, not to make you feel good, because a few weeks down the track they'll invariably come back and say, I don't think the medication's working. I don't feel so well. But when you really explore, the functioning aspect will be maintained, but that sort of the basic sort of response to the mood enhancing effect might just drop. Yeah.
And as GPs, can we adjust the dose if we're doing sort of a shared prescribing model? Can we adjust without discussing with you? Or?
Yeah, look, I think the legislation there, I've got a slide there which you might be able to, the legislation says that you can't increase doses unilaterally. You have to get the psychiatrist's opinion on that, and I'm pretty sure I've sort of mentioned that somewhere. So I think they do generally prescribe 2 yearly sort of reviews anyway, I think.
Great, we're running out of time. So many questions. I'm sure that if we've got more questions, we could forward them to you. So, no, that was great, Jyoti. Thank you so much. It's definitely a common request in general practice for a referral to you or one of your colleagues. The wait list is difficult as well, but certainly the questions were great, especially the non-pharmacological managements and whether it's seeing a psychologist or a good ADHD coach, but lots of tips for us there. So thank you so much.
No problem.
That was great. So just a reminder for everyone to go through the Slido to